Reinke space. What is this? Reinke space and its clinical significance is a usually asked short note both for undergraduates and postgraduates. And if you don't know what Reinke space is in clinical side, better not to look even to look into the larynx of the patient, because all disorders related to voice you can't treat without knowing this Reinke space. So I previously explained on Reinke space on anatomy of larynx, and again along with the anatomy of vocal cords. So link is given in the description box, please see that. So, once more I explain the anatomy of true vocal cords. So superficially there is epithelial layer which is formed by non-keratinizing stratified squamous epithelium. Okay. And inner to the mucous layer, submucosally, there is lamina propria. And this lamina propria there is 3 layers for lamina propria. This together we call it as lamina propria. And deep to the lamina propria, there is a muscular layer which is vocalis muscle, which is the internal part or the medial part of thyroarytenoid muscle. Okay, this is regarding the membranous portion of true vocal cords. From anterior commissure up to the vocal process of arytenoid comes the membranous part, the anterior 2/3. Epithelium which is non-keratinized, stratified squamous. And deep to that, I told you there are 3 layers for lamina propria. It's a superficial, intermediate and deep layer. Okay. So there is a superficial layer, there is an intermediate layer, and there is a deep layer. So superficial, intermediate and deep layer for this lamina propria. And the superficial layer of lamina propria is otherwise called the Reinke space. Okay. So the superficial layer of lamina propria is otherwise called Reinke space. So what is the difference between the anatomy or anatomical structures? So in the superficial layer of lamina propria, there is this lamina propria contain both collagen as well as elastin fibers, and this superficial layer contains both elastin and as well as collagen fiber, but they are very loosely arranged. Okay, so it is loosely arranged and it contains more of extracellular matrix, and this extracellular matrix is rich in hyaluronic acid. Okay, this is extracellular matrix which is rich in hyaluronic acid, and the collagen which contains here is a type 1 collagen. So the superficial layer of lamina propria is otherwise called the Reinke space, and it is the fibers are loosely arranged, and the extracellular matrix contain abundant hyaluronic acid and also type 1 collagen. Whereas this intermediate and deep layers, they are orderly arranged, or they are more packed, and this intermediate layer contain more of type 3 collagen, and also this deep layer of lamina propria contain more of both type 1 and also type 3 collagen fibers. So these two, this intermediate, they orderly arranged intermediate and deep form a single unit, and this is called the vocal ligament. Okay, so this superficial layer of lamina propria is called the Reinke space. Now you know what is Reinke space is. And these two, this Reinke space as well as the non-keratinizing stratified squamous epithelium, they work as a single unit which is called the cover. Along with the muscle layer. Muscle layer forms the body. So that describes the cover body, Hirano's cover body theory in case of physiology of phonition. Okay, so this is Reinke space. And what are the boundaries of this Reinke space? Let us see the boundaries of this space. From here you know, here there is the other side, the other vocal cord, true vocal cord comes. So this is medial and lateral. Medially, what is the boundary? Medially you have epithelium, epithelial layer, and laterally vocal ligament. So medial and lateral. Anterior, actually the vocal cord is like this. True vocal cord. Here is arytenoid, vocal process of arytenoid. So anteriorly, anterior commissure or the Broyles ligament. Okay. Anteriorly, anterior commissure. Posteriorly, arytenoid, vocal process of arytenoid. And also there is superior limit and an inferior limit. So superiorly, it is a superior arcuate line. What is superior arcuate line? Please see anatomy of vocal cord, video on anatomy of vocal cords. Superior arcuate line and inferiorly inferior arcuate line. Okay, so anatomy, then the boundaries of Reinke space. Okay, now we see what are the clinical significance of this Reinke space. Now you know that the Reinke space is loosely arranged and it contains free spaces and it contains extracellular matrix, and also in the Reinke space there is more of capillaries, but in the vocal ligament there is more of arterioles and venules. Okay, so there is space to move in the Reinke space, and in general what happens, if you are so flexible and adjusting, people will try to get advantage over you, isn't it? So they will try to sit on your head. Don't allow that. So here also, because it is loosely arranged and space to move, and it is more of capillaries, so exudative vascular stromal lesions can happen here. So what are they? One is vocal nodule, then vocal cord cyst, vocal cord hemorrhagic lesions, hemorrhagic polyp, or vocal cord polyps, and also Reinke's edema. As far as exam is concerned, each of these can be asked as separate short notes, and also very common in your clinical practice also. So all these are happening in this as an exudative vascular stromal lesions of the Reinke space. So all these have got some common characters and treatment is almost the same. Regarding each of them, I will explain in different classes. Also, sulcus vocalis and mucosal bridge. These two concepts are also associated with this Reinke space or the superficial lamina propria. What is sulcus vocalis? That is a strip of epithelium get invaginated into the Reinke space, forming a sulcus. That is due to so many other reasons. That is sulcus vocalis, and hemorrhagic bridge is actually a strip of epithelium with a central axis of connective tissue, mostly from this superficial lamina propria, and it is usually associated with sulcus. Mucosal bridge is usually associated with this vocal nodule or vocal cyst. It's a strip of epithelium with a central axis of connective tissue, mostly seen in this Reinke space. So all these are entities which are associated with this lamina propria superficial layer. The first symptom will be a change in voice. Patient can complain of dysphonia or dryness of throat. Then deteriorated voice quality will be breathy and husky voice with reduced pitch, especially in Reinke's edema. Rengis edema is mainly noted in females because of the voice change into a voice quality will be changed into a male voice type. It will be the pitch will be reduced and also the tightness of voice will increase. Okay. So deteriorated voice quality will happen, vocal fatigue, and if the patients are professional voice users, they will complain that the vocal range is reduced. They can't take high pitch, they can't do more of a humming type of singing like that, they will tell. So all these are common to these affections of the ringy space, and there will be minor differences in the voice in each of these headings that we will discuss along with a particular topic. So assessment or the investigation is usually multidimensional. You can go for an auditory perceptual evaluation, but the gold standard in the diagnosis is stroboscopy or in high speed or stroboscopy along with a high speed photography. So that is the gold standard in the diagnosis of glottic lesions. Photography. By this we can very well see the vibratory characteristics of the vocal fold, and if sometime in cases of vocal scar or sulcus vocalis, then it will be difficult to distinguish by doing a stroboscopy. So in that case you will need a micro laryngoscopy or a micro endoscopy of larynx. Along with doing by this micro laryngoscopy or micro endoscopy, you can also palpate the vocal fold and also can distinguish the epithelium, and if needed you can give a subepithelial infusion so that you can grade the sulcus vocalis and also can distinguish the vocal scar. Regarding treatment of lesions on the ringy space, so basically it is a cover, so there is vibratory function of the vocal fold. So any lesions in this cover area, either in the epithelium or in the ringy space, will cause changes in the vibratory pattern of the vocal folds. So that is why there is change in voice for the patient symptom. So in all these we have to approach this ringy space. So the first is medical or conservative management, that is ask the patient to do adequate vocal hygiene, then voice rest etc., voice therapy etc. And if it is not going well, if the conservative measures fail, then we have to go for a surgical treatment. So any lesions of the vocal fold, any lesions of this ringy space, we can approach it through the epithelium, isn't it? So in conservative surgical method, the approach is through the epithelium. Either we can make a micro flap on the over the epithelium and can remove this abnormality, whether it is a vocal nodule or cyst or a polyp, whatever it is, either using a cold instruments or laser or microdebriders, and that is we can go for a micro flap of the epithelium, or in other cases, especially the sulcus vocalis or scarring, then injection or other hydrogels or cell therapy or growth factor injections etc. That is through a conventional approach through this. And the latest one is a micro endoscopy of ringy space. The PGs can expect, residents can expect a short note from in the recent advance, micro endoscopic approach to ringy space. So through that we can go to this ringy space without causing damage to the epithelium. Without disrupting the epithelium, this ringy space can be approached. And through the endoscope again, all this, whether it is a removal of this one or injection or augmentation, whatever it is we can do. So that is regarding the ringy space. So ringy space is a superficial layer of lamina propria. It is a loosely arranged extracellular matrix, and mainly the deformity or the pathological changes which happen is an nodule, cyst, hemorrhagic polyp, vocal polyp or Reinke's edema, or a sulcus vocalis or a mucosal bridge. Assessment is mainly by stroboscopy and high-speed photography, and recently micro endoscopies are also there. And treatment is either conservative vocal hygiene and other vocal therapy measures, and if it is not going well or if it is failing, then we can go for surgical measures. Okay.